Fancy.
Hello, everybody. Welcome to this new webinar that we've got scheduled here with Chris Prue, our new education director. So really excited to look at kind of human movement analysis and what that means to the clinic and also to your patients. So Chris, with that said, I got a great backdrop here in a physical therapy clinic. So I'm going to let you take over and we'll run with it. All right. So over to you, buddy. Thank you.
All right. Thank you, Brandon. Thank you, Rana. All right, just to verify, Rana, you can see my screen in presentation mode, yes?
Yes, we can see it.
All right.
Yes, there you go.
Perfect. Well, thank you all for taking the time to listen to me speak. It's a very long title for a very relatively short discussion. So it's more of an introduction. And my goal here is really to kind of think about, you know, what the thought process is in sort of implementing human movement into the decision-making process and look at some of the transitions that we've done from a clinical perspective. As Brandon said, my name is Chris Prue, so I'm the Director of Education with DigitSoul. I'm also in private practice, so I focus a lot on neuromusculoskeletal as well as sports science. And the young lady that you see here is my daughter when she was 20 months old. And we had video recorded her because I was doing a presentation on motor development in training for the youth population. And ironically, at about a year prior to that, she was diagnosed with some movement disability. And had some specific therapy work done on her gross motor movement pattern known as gait. And so kind of a nice intro segue into what it is that we're going to talk about. I have two main key points that I really want to come across with this particular talk in the next 30 minutes or so. And then we'll have about 15 minutes where we can have some discussion or some questions or however we would like to use that. The first one is considering that gait is really part of a general movement screen and how we can look at a lot more than what's considered to be what gait analysis is sometimes thought of, which is just sort of looking at the lower extremity movement patterns, especially the foot and the ankle, but also taking into consideration how we can use it because of the premise and how gait is initiated and utilized by human locomotion is as a prevention, a performance, and a restoration tool. So getting some baseline data to establish how someone moves before they're injured to give us some indication as to maybe some things that we can do from a performance perspective if you're in that sports science realm. And then also specifically in the restoration piece, to utilize gait or locomotion to inform the clinical decision-making process. So we'll get into a little bit about what gait is. The intent is not to go into any great depth of a gait analysis or locomotion analysis, but like I said, just to lay that framework and to start to think about what's available to us today that wasn't available to us not too long ago, and how we can think about the utilization of this approach within the clinical setting. And it really does help to align with where we've been going from the conservative approach in healthcare, as well as a lot of the problems and issues that constitute a lot of the conditions that we see globally, including the amount of money spent on many of these conditions, such as chronic pain. So a brief historical perspective will define gait and locomotion, specifically looking at some of the more basic parameters. And there's reasons for that. One is we don't have a lot of time to get into any great detail, but to show that even those basic parameters have a lot of strength, a lot of merit to their interpretation in how we can utilize them easily and quickly based on today's technology within the clinic setting to help us treat our patients. Looking at the pathological conditions influenced by locomotion. In other words, what types of things could we utilize locomotion or gait analysis as part of our human movement analysis or assessment tools or techniques in evaluating our patient population? And then I'm going to go over an example of a decision tree and using locomotion influence in how it can help guide. And this was a specific patient, and it was an older adult patient that has a history of falls and mobility disorders. And then we'll have a brief conclusion, and then we'll be able to open it up for some questions. So I have a long history of whenever I'm presenting on topics to sort of look at the evolution of something, because it gives us some indication as to where we were and maybe why we're in this discussion today. And a lot of that is going to be driven through technology and where it fits within the clinical setting. So historically, looking at Da Vinci and Galileo and Kepler and Descartes and Newton. So a lot of those earlier views of human movement were somewhat from an artistic point of view, anatomical points of view. Obviously, they really couldn't look inside someone. So there was a lot of cadaveric specimens that were being utilized to look at the anatomical features and then sort of retrograde or look at, after someone is no longer alive, what's going on inside of that person and how some of these mechanics were utilized. And then from René Descartes, so for example, specifically looking at the connection between behavior patterns and cognition to human movement, which was way ahead of his time, obviously, back in the 15 to 1600s. And then, of course, everyone knows who Isaac Newton is in a lot of the physics principles that we still utilize today. Fast forward to a couple hundred years and looking into the 1800s, and that's where we actually started to see some quantitative analysis, where measures were being taken to really analyze gait from a more specific and normative value, and to put measures to those patterns that we see as fairly repeatable, and to potentially use that to inform us in terms of what it is that we can look at in human motion. And then also in the 1800s, a little bit later than that, of course, technology has a major role in all of this, but now being able to use photographs. They're still photographs, but taking multiple photographs to look at the different positions as someone is moving through a locomotion or a movement pattern, right? Because that way they can actually do some measures, take some quantification, and go back and look at things from a historical perspective, but take an analysis and then compare it as a pre and post as we think of today. In other words, maybe before somebody got injured, after somebody got injured, or as we see in a clinical setting, as we begin to treat them, and then after we treat them for a period of time. Also in the late 1800s, more of the biomechanical aspect and looking at energy expenditure, and probably some of our earliest times when we're looking at what are referred to as segmental models. So those of you that have gone through a human analysis education program for motion capture specifically is where we use those points and we put them on the articulations. So along the femur, both points of the femur, the forearm, and so on and so forth, to create that segmental model. So that way, when we have a rigid model and it moves through space, the length of that model doesn't change, and therefore we're able to calculate things like forces or torques, and as a result of that, look at things like energy expenditure. So through that historical perspective, the technology has been a large driver and motivator in that. And we see this throughout many other industries too, that there's a lot of overlap in the utilization of human movement. Certainly in sports science, but even what some people probably watch on a daily basis is things like television and movies, to where a lot of those CGI graphics are generated as a result of using some form of motion capture systems. They're very expensive, however. And so that's always been a bit of a disconnect between what we've seen in the education systems and then what we've been able to do in practice. Even for myself, my personal experience in higher education and being responsible for running laboratories, having access to a lot of high-end and really expensive equipment, it was a challenge to work with many, many people, all of my students, for example, but also the transition and to be able to apply that from that clinical perspective. So you had to have a lot of background and technique in the analysis of looking at that data and being able to create and convert that into something more usable from that clinical perspective. So there's been many barriers identified in that disconnect between academia and what we tend to do in the clinic. So it has been analyzed, and it is something that we are aware of as a barrier. So one of the things I always, talk to when I'm working with clinicians and the manufacturers alike, and certainly researchers, is we need to bridge that gap. And that gap is looking at the level of the technology, the ease of the technology, and the amount of time that it takes to deliver certain aspects. Now, we don't like to talk a lot about money when we're treating patients, because we're trying to just do the good thing. But to be able to facilitate a lot of those treatments and make more people better, time is of the essence, because we only have so much of it. And so we need to make sure that we're very efficient in our applications to make sure that we can take care of as many patients as possible. The other interesting thing when we look at the technological developments of many things that we deal with is it also has an influence on many of the conditions that we're treating. So everyone has probably seen this graphic, the evolution of humankind, and it transitions from basically being a quadruped to a biped to eventually sitting down. And we find that in many technological markets or many industrial markets, we find that about 80% of the people that are in the workforce are sedentary throughout the entire day. So that creates a whole addition of some of the problems that we have to deal with from a clinical perspective. And so very different in addressing someone who has a sedentary condition compared to someone who has a physical activity movement related condition, right? So difference between athletics and sort of that general population. And I know we've got people on from all over the world, but in any developed nation, it's fairly consistent. What's also interesting is in any nation, we share some similarities in some of these problems, such as low back pain being really high on the list as a problem regarding mobility. So as a result of this technology, it's also created some evolution in the clinic setting. I really like this quote by Liu and Chang, because it sort of brings together, the addition of the technology and the development of the products that we have available to us. And incidentally, as a result of technology, the prices also are reduced dramatically. But their implication is that through the study, and it's a reminder that through the study of all of these forces and movements and interactions, it allows us to have some insight as to the quality of life. And I specifically like to connect that to something like gait. So for example, we may like to do sprinting activities or throw a medicine ball or do many things that we might see on an athletic field with that particular population. But for the majority of people that come into the clinic with chronic pain and chronic conditions, which is typically the largest percentage of revenue spent in healthcare of the GDP of any developed nation. And so that's why chronic pain and those conditions are very, very important to us. So we can kind of refer that to a quality of life because there is this connection. So what's interesting is being able to have some insight as to what those problems are, not just on the individual level, but as we think about many of these conditions have comorbidities, right? So for example, yes, people can have diabetes and can have the side effects of uncontrolled diabetes by themselves, but it's unusual. It's typically related with things like sedentaryism. And then, of course, sedentaryism is also related to other conditions like obesity and cancer and cardiovascular disease. So we like to have a measure. We like to have tools that we can evaluate things that have some overlap in terms of what is going on with a patient and letting us know. So with this information, it allows us the optimal ability to create manipulations to the patterns and the applications that we have in the clinical setting to make sure that we're on the right track. And when we look at something that's very consistent as an assessment tool or an assessment model across many different pathologies, it also makes it easier to know that we are having more of an impact on a lot more of those comorbidities versus just one of those conditions, right? And it's not to say that we remove some of those more specific or narrowed focus down, such as range of motion of a specific joint, but it's to look at the overall sum of all of those parts that we're dealing with in the clinic setting. And it may also help to facilitate improvements or changes in some of those comorbidities. Typically, patients come in because they often have one thing that brings them into the clinic. They have low back pain, they have foot pain, whatever the condition may be. But again, especially if it's related to chronic pain or some of these other comorbidities, they have multiple problems. And that's a big challenge for us in the clinic, especially depending on the model at which you get reimbursed or paid by either the individuals, third-party payers, commercial insurance, or the government programs, to make sure that we can take the best care of people that we possibly can. So having that opportunity to have some oversight and insight to what's going on with patients can be very important. Now, specifically when we're looking at that human movement analysis, gait or locomotion is something that is becoming so much more popular today, even though, as we've already identified, it's been around a long time, but it's been challenging to implement because of the technique. And there was always this disperse variations between, it's either you're using a lot of technology or you're not using hardly any technology. So we're just using some observations. So we need to find that sort of happy medium. And when clinicians are asked, what do you think when you hear of gait analysis? And the answer usually is it's something very technologically driven. It's something that they may have seen in school. Or on the flip side, it's something that I just watch somebody, maybe I use a camera, and it's more of a qualitative assessment. And there's nothing wrong with that. Studies have shown that qualitative assessment does provide us some good information. And in fact, the example I'm going to use here in a moment, did it require an extensive gait analysis on this patient? Not to identify some of what we consider to be the more obvious things, but to look at some of the transitions as a result of treating patients. It may be important to have a little bit more data involved in that process. And if that comes with a short duration, in other words, not a lot of time investment from me or the patients, and I'll talk about this in a moment here when we look at adoption versus adaption, right, is how can I integrate something new into the clinic without completely disrupting everything that I need to do, and making sure that it addresses the needs for me and my patients. So here's another example by Baker et al. in 2016. And again, they're looking at, gait analysis as being this quantitative assessment for a lot of things that have some lower extremity conditions, but even those non-musculoskeletal conditions. And a lot of these typically end with, but we need to figure out better ways to accomplish this. So the two main areas where this became very popular and where the investment was very common is in like cerebral palsy, right? So with our children, and that's where people typically had to go to a very specialized area, a very specialized hospital or clinic setting that had that amount of information. Here's another example that it's the study of animal locomotion, more specifically looking at human motion, and it's augmented through instrumentation along with using our brain and our eyes and trying to evaluate the activity of the muscle. That's probably even a more broad term, but what we have available to us today is really giving us the opportunity to expand that. And that's why the consensus or the general thought process of gait analysis still remains more so in that lower extremity. So remember, one of my key points is to get us to start to think about, why locomotion, why gait in terms of an overall human movement assessment, and hopefully I'll provide some more information on that. But there's a couple different ways that we look at gait analysis, and it's referred to as the bottom up or the top down. And some of this can be both qualitative as well as quantitative, right? So from the top down, if you're looking at the upper extremities and movement patterns and spinal positions, orientation of some of the structures involved that are either supposed to be more stationary or supposed to be more mobile. And then we can look at the bottom up orientation, which is what a lot of people think of when they think about gait analysis is, you know, what's going on in the foot and potentially the ankle and maybe a little bit higher. And then some of the metrics that are involved in both of those pieces. And then what's been lost a lot in that translation is really the details. It's the details that are lost when we don't have the technology behind us to really look at human movement assessment and to be more sensitive, right? And so you've learned about orthopedic, neurological tests, and we learn about sensitivity, right? We learn about the accuracy. So looking at, is it sensitive enough to actually detect a problem, right? And then is it capable of really determining or telling us, you know, what that problem actually is? So the benefit of the technology really gives us this opportunity to look at that degree of sensitivity like we've never looked at before. And even if it doesn't tell us exactly what the problem is, because again, does a patient only have one problem when they come in? And the answer is usually not. If you're in the sports world and you work a lot with the high level of physical activity, that's a little bit more common. But those of us in the general population and where we spend a lot of the money associated with healthcare, no, it's the people that have these multiple problems. So there are still barriers in that arena of where we're trying to implement this type of technology and bring it to a level at which we can utilize it and really make that change, right? And so we need to make sure that, you know, it meets all of that criteria, right? Because it's not as simple just to integrate something into the clinic, right? It needs to be effective, it needs to be time efficient, and it needs to be easy, and there needs to be a cost associated with it, right? And we look at return on investment. You know, the business people look at it, you know, from money. We look at it in terms of, you know, how many patients that we can treat and what we can do to actually make some of those people better, which at the end also does translate into some level of revenue stream. So let's look at the basics of gait and really how does that match up, and why am I talking about some of these other conditions other than just lower extremity? So it's a very time-oriented condition, and that's why we have this term called spatiotemporal. And so those are parameters associated with time duration as well as the movement. So the two basic components are going to be the stance phase and the swing phase. So the stance phase is when someone is in contact with the ground, and then the swing phase is when someone is moving their leg through the air, right? And so there's always going to be at least one foot in contact with the ground when we're looking at walking analyses. Running's different because there is going to be a flight phase, but in walking analyses, there's always going to be a contact time. We actually get some interesting information because we can look at some of the orientation of the feet, but while they're in contact, there's other things that are going on throughout the body that can give us some insight as to what's going on with the patient. And then the swing phase is when they're picking up their foot and they're moving it across the ground and they're getting ready to take that next step. So the step is the distance between two contacts of the alternating feet, and then the stride is looking at that one full cycle of one step to the next step. Now, here's some other things to take into consideration, because these are metrics. These are things that we can't really see with the naked eye, but what we found out is they're very important at indicating some of the problems that are going on with patients. And because of technology, it really allows us to emphasize that level of sensitivity that otherwise we couldn't get before. So those are looking at the biomechanical and mechanical forces, right? So the movement patterns, specifically looking at stresses and orientations of the anatomical features, which is biomechanics, but also the forces, the ground reaction forces, how someone impacts the ground, how much time they spend in contact with the ground. And then there's the neuromuscular. And that was sort of my earlier interest in gait analysis from a human movement perspective, because I really wanted to investigate what was going on with the autonomic nervous system. And even then, it was more to do with what was going on in the athletic population, because recovery from intense bouts of training was something of great importance to us. But from a clinical perspective, the neuromuscular component of gait is really what makes it such a high value sell to my patients when I want to do an overall movement assessment. Why? Because there's a lot of reflexive patterns, so it gives us some insight as to the central nervous system, how that's functioning, and then a lot of voluntary motor control strategies that is sort of that overlap between what should be normal patterns in the patient, where they might be making some compensation or strategies that might not be good for them. They may not know about it. And some of those can occur over such long periods of time, they just don't recognize it. And that can be difficult for us to actually see as well sometimes. So breaking this down a little bit further is we actually have some standardized time frames, distances. So those are referred to as normative data, right? In other words, the amount of time that someone should stay in contact with the ground and the amount of time that they spend in swing phase. So there are some averages, right, within some standard deviations that tell us those particular parameters. And so that's a really good thing, because that means that we can use this as a very simple test to match this up against, some normative data, just like we do with heart rate and blood pressure and things of those nature, to know that someone is not working appropriately. And then we have symmetry, cadence, and speed. Symmetry, it seems like it's so simple and easy, but symmetry is looking at, in this case, the contact time, the amount of time that's spent in contact with the ground. Why is that important? Well, as we start to see some deviation in contact time, it gives us some insight as to what might be going on with the patient. So if they're spending too much time in that contact phase on that one side, it could be because they've got some weakness. Or on the flip side, maybe they're spending too little time on that other side, and maybe there's some pain that's causing that. We can also look at some of the other orientations of the features with regards to the human movement pattern that are a little bit more detailed, but this is a really simple and easy way to take this into consideration. Speed. Speed is another one. And so speed, very simply put, if you ask someone, an adult, to walk at a normal, comfortable pace as though they needed to get someplace, not in a hurry, but they had intent of going someplace, that average speed is about 3 miles per hour or about 5 kilometers an hour. And that's important too, because what happens is they start to slow that down. There's a reason behind that. But I can't always see if they're slowing down within that standard deviation that's going to be good without, using some sort of assessment tool with that. And then the cadence is the number of steps per minute. So this is where we're actually going to take into consideration that speed, along with the length and the duration of those steps. And again, we've got some normative data. And what you're looking at here, they're all in green. Symmetry is rarely 100%. And the reason is that we have this complex motor theory to us that there should be some deviation, right? And depending on the data, it might be as much as 10%. So if I saw 90% or 91%, that might actually be okay. Especially when it comes to a walking pattern, especially in an older adult where we tend to see those deviations, as well as speed has an influence on that. And so what's interesting, technology can actually tease that out for us. So I don't have to spend a lot of time doing calculations, and we get that information right away. So looking at, well, what kinds of things can we actually assess? Well, I wanted to remove the obvious, which is foot and ankle conditions, because that is what most people think of with gait. So that wouldn't be surprising if I said we can look at foot and ankle conditions, right? We can also look at relative low extremity conditions as well. Behavior and cognition. Behavior and cognition also influences gait patterns, right? And that could be related to either something that's going on from a neurodegenerative disorder. There could be problems with the medication that they're taking. We've seen studies that they've taken identical twins who have almost exact symmetrical or identical features between the two, but they have slightly different gait patterns, and it's because they have different personalities and attitudes. Neurodegenerative disorders, and as you can imagine, because we're highly reflexive when it comes to gait, anything that influences the central nervous system can actually have an influence on gait patterns. Obesity, well, as we increase in our body mass, it may change our center of mass and therefore also have a negative influence on some of that basic data that we just looked at, and even some of the more detailed data. With that increase in body mass, if I don't compensate for that by improving in my overall strength, then I want to make sure that I can compensate for that. And what we find is obesity patients can't necessarily do that. And then I think there's some obvious osteoarthritis in the hip and knee, and then maybe again some not so obvious. I do a lot of low back pain patients, and they consistently have abnormalities with their gait patterns. And the interesting thing is, because of the sensitivity and technology, I actually have the ability to see what's changed as a result of the pre and post treatments, and sometimes even within one session. So how can I use this to inform my clinical decision-making process? Is it as good as maybe some of the other tools out there? And I'll answer it's probably better, right? And the reason is that technology is something that surrounds us, and it's more about how are we using technology. You can't get away from it. But one of the things that we all probably battle with is compliance. And so being able to provide that data, something that's very, very common and something that most people can relate to, and it's actually one of the reasons why some people actually come into the office, is they have problems with their gait, with their walking. And so it's a really big tool with regards to compliance, let alone some of that information. We're finding more today than ever that patient satisfaction does actually have an influence, not only on our clinical business, but also on actual clinical outcomes, right? And it's what's going on up here in their brain. So here's a patient profile, and it's a female. She's 83 years old. She's in independent living. She's living on her own. Previous history of falls, but she came in because of cervical myelopathy and bilateral knee pain, so severe osteoarthritis for several years. So a history of falls, and actually some really severe falls. And the last one before she came in to see us, I'll show you here a picture in a moment. And as a result of a fall, fractured her tibial plateau, fracture of the styloid process of the radius, and also a fracture in the orbit. And this was all from what was considered to be a relatively very, very simple fall that, you know, it should have been picked up that she really needed some interventions with regards to her lifestyle and her living. She's on several medications, including some that are mood altering, such as amitriptyline, which is actually an antidepressant being used for her headaches, and then gabapentin, which is a pain medication for neurological conditions, high blood pressure, high cholesterol, diabetes. You can see the profile here, and there's a lot of comorbidities. Actually received multiple sessions and situations of occupational therapy. So that's the one where they help you, regain your functional status in activities of daily living. Physical therapy, also neurological consults with neurologist and neurosurgeon. And none of them actually looked at her profile with regards to fall risk. And that's a problem, because the fall risk situation can be very, very detrimental. So here's her profile. And I'd mentioned this earlier. I didn't need to do a really technical analysis to know that, her gait's not that great, but now we've got some really good data that we can provide and we can show. Her symmetry is actually pretty good, and you can see that in the way that she walks. But when told to walk comfortably, she only walks at 0.9 miles per hour, right? Which is what, about 7 kilometers, 6 kilometers an hour. And then her cadence is also extremely low. And when we look at her walking profile, again, most people would say, well, that's kind of about in the normal as far as the stance in the swing phase. But if you look at her steps and her stride lengths, they are very, very short. She's taking extremely short steps. And when we get into the basics of these profiles, and you look at her stride duration relative to her speed, the amount of time that she takes, she walks very, very slow. Her stride length is really, really short. and she spends a lot of time in that stance phase. She does not like to be in the air. She does not like to be in swing phase if she doesn't have to, because she doesn't feel stable. And one of the reasons is she actually has a fear of falling. So when we look at what are we supposed to do with this patient, there's always additional considerations. What are the other metrics? We do have some other metrics, but these basic ones actually provide a really good overview of some other things. Now, this is in addition to your typical evaluation and examination. So it is in combination with my orthopedic and neurological findings, and we do correlate those. So we set goals for her to manage her knee pain, improve her extensor strength, and reduce her risk of fall, because we also actually did look at something like foot clearance as well as the variability. And she was on, this was over ground walking, so it wasn't on a treadmill. She was using a cane. The other thing that we suggested is possibly using a full walker instead of using a cane. I don't have the additional data that we did on her analysis, but you could see that her walking profile and her gait line, she really was compensating on that left side, which is the side that she was actually holding the cane on. So we had some balance strategies. We really focused on strengthening. Strengthening was a key point for her, because that's a big limitation in part of her knee pain. So her knee pain is associated with part of her problems with regards to her locomotion, but it's also her balance and her fear of falling, because she's had so many falls that she does not want to fall again. And related to that, we needed to have a discussion regarding her behavior modification. So I mentioned earlier, adapting versus adopting. And that's why it's important to be able to consider, the implementation of something that's relatively simple, where you don't need to, reestablish your entire clinical practice. Because if you're somewhat successful, that's just not going to work. And so that's the beauty of movement analysis and being able to pick and choose the components that are necessary for you and your patients. As I mentioned earlier, it provides a lot of insight to many, many different conditions. And I would argue that it's probably one of the best baseline assessment tools. And so we utilize it for an athletic population. It's part of our pre-screening. We utilize it for all of our patients. And that way it gives us some indication as to when things are not going properly. And because of the sensitivity that it delivers, it again really provides a lot of information for us and gives us that opportunity to be more specific and detailed, but improve that compliance, making sure that patients actually finish and complete. So this is that young girl I showed at the beginning who is now a long distance runner. And I actually analyze her on a regular basis, because this is my daughter and I want to make sure that she is moving well. So, all right, I went a little bit over, but thank you so much. I appreciate your time. If you're looking for more information on human movement analysis, check out digitalpro.com and check out what you can get from that particular system. And I'm going to ask you, please fill out your surveys after the presentation. We would love to get more information from you, more things that we can provide with regards to more content. Is it the right time? All those sorts of things. So it really gives us a lot of information that's good for you as well.
Thank you so much, Chris. We have a couple of questions. So the first one is from Sue Hancock. She's asking us what kind of system we use to get this detailed data. So would you kindly tell them a little bit about Digital Pro?
I can do that. So as I mentioned, I used to be in a lab, so I had access to motion capture and force plate analysis. But the problem was we were stuck in a lab, and my transition to the Digital Pro allows me to take it outside into the environment. So actually, I sometimes do home visits. So the technology is using an inertial motion unit, and it's been validated against motion capture, force platform, but it's very small and tiny. It goes into an insert into the shoe that I put in the patient's shoe, and it captures that data. It produces the analysis, and also give you some information about what that analysis is that I can then use in my my interventions.
Okay, there's another question from Michael. He's saying, how big a cohort did you use for the PodosMart data? Only adults? How young people can use the PodosMart test on?
Yeah, that's a good question. So I believe there are 2 validation studies that were done on the product, and then it's revalidated in other very large cohorts. Unfortunately, I'm not familiar with the PodosMart data, but it has been validated internally with over 400,000 analyses. And so when you look at the validation, so you need to make sure that it measures what it's supposed to be measuring. And I think that they've done a great job at establishing that with the number of analyses. And the other thing that I left out with my previous answer was it's using an artificial intelligence and a motor learning algorithm. So it's constantly feeding the system. So the algorithm, in looking at some of its normative data, has more data points than I think the combination of putting most all-gate analysis studies together, looking at the reliability of those basic parameters and metrics.
Any other questions? So we have a question. How can this be used for long distance running athletes? Are there norms available to compare the athletes?
Yeah, so that's another really good question, and something else I left out. Because the inserts actually go into the foot sole, right, inside of the shoe, the person can actually go ahead and do their run. When they come back in contact with the device that you're using to upload the data for computation, it will give you all of that information. And on the analysis, you can break down different segments. So you can look at a point on the 1st kilometer, on the 2nd kilometer, the 4th kilometer, based on the time. So it also gives you that timestamp. And so there's normative data on the running analysis with regards to some of the parameters. But again, I mean, some of that information, especially when it comes to running, and depending on what you're looking at, may be more individual. So it's interesting when we create what's referred to as a challenge. So having them run a 5K pace at one speed, and then having them run it at a different speed, or running different kilometers at different speeds, you can actually compare that data within the same person.
There's a part of the question by Michael that you missed responding to. Can you test children with PodosMart or Digital Pro? And maybe I have to say something that Digital Pro is an upgrade of the PodosMart system. So basically, it works similarly, but it's easier to use outdoors. It utilizes an application that you install on your mobile so that you can start and end the analysis. And then we do not need the Podo station. For the ones who are familiar with PodosMart, we wouldn't be connecting using the Podo station. You would be using your mobile phone or a tablet instead. So it's easier to use. The insoles are more flexible, and rather than having thick ones with battery included, so now the insoles are thin, flexible, and we just insert the pods inside in order to do the analysis. And now I'll let Chris reply concerning the children.
Yeah, no, thank you. So regarding the children, so one of the things that's going on right now is a validation and reliability effort on children, specifically looking at some of that normative data. Now, I will say that the challenge of normative data in children is it changes relative to behavior patterns and whatnot. Where I think most of us are looking for is it valid? Is it reliable in terms of it capturing all of those metrics? And what I found is the answer is yes. But because the profile of a child is going to be different than the profile of an adult, the normative data that is in the system right now would not be applicable to the child at this moment. But I still use the data because it provides me the symmetry, the cadence, the speed, the angulation, and things like that. I just can't match it up to the normative data of an adult.
And I would like to add that soon, very soon, we will be having special insoles for children with various kid sizes. So soon it will be available as well. We have a question from Siret. Thank you for the presentation. When using the digit sole inserts, can any type of shoe be used?
Sort of. It wants to be fairly neutral because the sensor is relative to the horizontal of the ground. So what I typically recommend to people or patients is to use a fairly neutral shoe, a comfortable shoe, and a shoe that they typically use on a regular basis. Now, I also test people in maybe their performance shoes and their running shoes, because we can then look at some of that relationship to the normative data. And some things we found is what people consider to be, you know, a performance shoe resulted in some abnormalities between symmetry and some of their gait patterns to basically identify that maybe that's not the best shoe for them. But using a neutral shoe, using a comfortable walking shoe is what's highly recommended, so they can actually walk at their normal pace.
We have another question from Meg. How does the insert work with runners that already have inserts for overpronation?
Yeah, so they would need to go under any sort of insert, and the problem with that may be their foot may not fit into the shoe appropriately anymore. So it's fairly thin. It's meant to remove the under insole that comes with the product, with the shoe, and to slide that in so it makes it fairly neutral. So if you are then using an additional insert that normally goes on top of the manufacturer's insert, then you should be okay. The problem is that if you're using an insert that is to take the place of the manufacturer's insert, you may lose some of that space.
We have a question from Elias. Can you use the technology in barefoot minimal shoe runners as well?
That's a very good question. So I've tried that, and I can use it on a minimal shoe, but I can't use it barefoot because it needs to be in contact with the foot. So the sensor is embedded inside of the insert. So the inserts are fairly small, but again, it does take up some space. So you can fit it into a minimalist shoe because those are very, very neutral. And it has provided us some really good data, but they do need to wear something.
There's a question by Theodore. What are the metrics that you assess in order to judge if a specific shoe is good or not for an athlete or a patient?
Well, you can certainly use the basic metrics in the basic profile. So in the running analysis, it gives you very similar information as I showed in the walking analysis, except there's going to be the addition of the flight phase, right? So we know that there's no support during that particular phase. You also get ground contact forces. And so that could be an indication either because of their shoe or the way that they strike, right? So either being a heel striker or a midfoot striker. And sometimes we're using shoes or inserts to change that pattern or profile. We also get angulation when we're looking at foot position relative to the horizontal. So it's not exactly pronation, supination, but it's a combination of pronation, supination, inversion, eversion. And so again, having someone try the different types of shoes to look at some of those orientations as well as the overall performance factors, such as, you know, if I put them in a shoe and have that that person attempt to run at their normal pace, right? Either measured by velocity, measured by time, or measured by heart rate or RPE, and then try the different shoe with the insert. That will give you some of that indication, along with the performance-based outcome measure, which is obviously going to be their time.
There's a question from Dan. Can you direct us as to where we can access data, research on digital results, reports indicating or suggesting certain musculoskeletal or joint abnormalities? This would be NB for consideration in rehabilitation protocols or design.
Yeah, so if you go to the website, so the website digitalpro.com has supportive documentation on the product itself. And from there, you can also download the interpretation manuals for both walking and running, and you'll get more in-depth information regarding all of the parameters that you can evaluate with this particular product.
There are also links to the validation studies and the published research as well on the website.
Yep.
There's a question from Amanda. Please clarify PodoSmart or Digital and different systems. Just a second. So to clarify the difference between Digital Pro and PodoSmart, and that Digital Pro can be used remotely outside the clinic space, but PodoSmart cannot. Would you like to answer that, Chris? Or shall I?
I cannot, because I've never used the.
Okay, I've used both.
I'm not familiar with the PodoSmart. Yeah. Okay.
Okay, I've used both. So in fact, PodoSmart connects to the system using something that we call a PodoStation. So it's a small box like this, and this needs to connect to the Wi-Fi in order to capture the data from the sensors and transmit them to be analyzed. So in order not to have to connect always through a Wi-Fi, so the new system, which is the Digital Pro, which is an upgrade, does not need that box to connect. It will use an application that you install on your mobile phone to do that. So basically, that's why we say it's easier to use, and you could use it outdoors. Now, you can still use your PodoSmart outdoors if you have a Wi-Fi connection, or by using your telephone as a hotspot. I hope I've answered your questions, Amanda. We have some more questions. So Siret, continuing with my questions. So when having a patient who has, e.g., a tight gastroc muscle and prefers to wear a slight heel, would you tell them to put on a different kind of sneaker or stay in their chosen shoe?
Well, I think that depends on whether or not their chosen shoe is appropriate or proper. I mean, me personally, if you're asking me personally, I always just try the insert in their existing shoe. And the reason is if they are a patient that can't buy new shoes, doesn't want to buy new shoes, maybe these are new shoes, then maybe we can correct them to some extent. If I'm being honest with patients, and we determine that their shoes are part of the problem, then we may recommend a different shoe, as well as potentially using an insert.
One more question from Elias. Have you used this technology in prosthetic limbs? And if so, can you give us your experience? I guess Paralympic athletes with prosthetic limbs would benefit from such a technology, and he's thanking us for the presentation.
Yeah. Oh, that's a great question. And so I have not with this system. I've worked with Paralympians in other aspects. So the way that this system is designed is to only be so far away from what's considered to be the normative data, of the typical patient population. And so people with prosthetics will be too far out typically of the standard deviation, and it may not pick up their profile. And so that's potentially one of the limitations, but we haven't really spent a lot of time in that direction that I'm familiar with. but we have had some people interested in doing some work there.
We have a question from Ramsey. I have used the PodoSmart insoles on an athlete on the anti-gravity treadmill and set the parameters at 50% of body weight, but the expected reduction in force was not 50%, more like 25% reduction in force. Any research been done on using PodoSmart insoles on an anti-gravity treadmill?
Not that I'm familiar with, and that I think that changes things a little bit. If you look at the way that the inertial motion unit is working, so it's working on a velocity spectrum, how quickly it's moving and rate of change relative to the person's body mass. So it's not actually a contact system like a force platform, and so it may not be appropriate on that particular device. That's my sense of what could be happening.
Okay, I don't think we have any more questions, but I'm just gonna post something on the chat. So basically, if you would like to have an attendance certificate, please do not hesitate to email me. I posted my email there for you, and we would like you please to take not more than a couple of minutes to fill out our survey form. This is to help us provide you with better webinars next time, and we really thank you for your time and for taking for doing the effort and joining us, and we look forward to seeing you in future webinars. We're going to do more of these, we promise.
Thank you all for your time. Have a good night.
Have a good night, everybody. Thank you, Chris. So thank you, everybody, and good night. So Anne, could you try to click the link I sent, the last one I sent? Thank you, Suan. Okay, perfect. Thank you, everybody, and looking forward to your replies, your replies to the survey, and to seeing you in future webinars. Have a good night, everybody.